we have Professor Hossam join us finally here. A little bit introduction for Professor Hossam Ghazi, a renowned interventional thyroidologist from Egypt, and Professor Hossam is Associate Professor of Medicine at Masura Faculty of Medicine and also the President of Pan-Arab Society of Interventional Endocrinology and Diabetes Technology. So now, Professor Hossam will share us about from diagnosis to ablation, the endocrine perspective on thyroid interventions. Thank you.
Okay, hello everyone. Good morning, good afternoon, wherever you are. First of all, I'd like to thank my friends in the CCMA to organize this webinar with the PASID, and it's my great pleasure to join you here in my lecture with Professor Bulent. Actually, is my big brother, and I learned from him a lot. I visited him in his center in Antalya, and a lot of works and a lot of friendships are gathering with us. And even some of my information today, I will share it. I know I knew it from him. I'm from Mansoura city, which is about 70 kilometers to the north of Cairo. And this is my hospital, practice private medicine in my clinic. Today in my agenda, I will talk about from the endocrine perspective about the introduction and the epidemiology of the thyroid nodules. Then I will talk about the chemical ablation for thyroid nodules. Then what about the thermal ablation, how it's different from the surgery, what is the agreeable indications and the contraindications, and the clinical evidence and the position about this in the guidelines. Then my summary and my take-home message for my young friend and those who want to get in the career of the thyroid thermal ablation. First of all, thyroid nodule refer to any abnormal growth that form a mass or a lump in the thyroid gland. Thyroid nodules is very common, either to be found clinically or incidentally. As an endocrinologist, we have a different protocol if we are dealing for adrenal mass or pituitary mass, for example, which are found incidentally during any radiological investigation. Or if I'm a clinician or endocrinologist, I order from the patient to have CT or MRI on the brain or the abdomen or so on. So the clinically found is different protocol in the management if incidentally found. But does not occur in the thyroid. If I'm dealing with a thyroid nodule, it is either clinically found, the patient's complaining from symptoms suggesting hypo or hyperthyroidism, the patient noticed that he's having a neck swelling. This is a clinically found thyroid nodule, or incidentally found during scanning for carotid duplex, MRI on the neck, or CT chest. All of this are similar protocol. In the US, more than 50% of the population having thyroid nodules, and about 7% clinically found nodules are present. And with advancing of the age, it increases the prevalence, and also it is more common in the females than the males. In Egypt here, we conducted a study, and we found that it is about 1/5 of the Egyptian population in my city is having thyroid nodules, and it is more in type 2 diabetes rather than normal population. Till a few years ago, if the patient is having euthyroid benign goiter or nodule causing compressive or cosmetic problems, there is no treatment apart from the surgery. Fortunately, that majority, more than 95% of the thyroid nodules, either clinically or incidentally found, are benign. And for the benign thyroid nodules, we have a lot of management options are available. The first option are the gold standard, the curative option, which is the surgical removal. But nowadays, I think that the surgery is indicated mainly for the most of the thyroid malignancies. If there is a huge retrosternal extension, if there is a toxic multinodular goiter, if there is a diffuse thyroid Graves' disease, which is not, if the patient can't afford the thermal ablation, I think this is the indication for the surgical treatment. But there is a lot of other options are available for thyroid nodules. If the patient is having a toxic nodule, radioactive iodine is there, and it is a very effective method. But there is two issues should be put in your mind. Number one, that the patient should delay the fertility or the pregnancy 4 to 6 months after the radioactive iodine, and it is contraindicated, of course, in the patient if the patient or the lady is pregnant or lactating. Number two, that if the thyroid parenchyma is taking some of the scan and taking some of the radioactive iodine, a lot of patients may go for hypothyroidism after the radioactive iodine, which is needing the lifelong replacement therapy, but this is not occur in all the cases. If the nodule is cystic or mainly cystic, we can aspirate this colloid materials or fluid or hemorrhagic fluid, and we can inject substance to make a chemical ablation. But this is not good for the mainly solid nodule. It is very perfect and very good and working excellent in the cystic or mainly cystic nodules. This chemical substance could be ethanol, more than 95% concentration, could be polydecanol, could be bleomycin, could be tetracycline, whatever the chemical substance, but it is a chemical substance to cause fibrosis and shrinkage of the thyroid cyst. Finally, the thermal ablation, which is the magic, and it is a revolution in the management of thyroid nodules, and I will talk about it. When I put the probe of the ultrasound on a neck swelling and I see this, it is a very, very, very lovely scene for me. Because just if you are aspirating the fluid there and inject the chemical substance, whatever you are injecting, majority of cases after 1 or 2 or 3 sessions, there will be fibrosis under local anesthesia with a relatively cheap problem and without any complications. I learned also this from Professor Poland when I visited him in his center, and we conducted a research to compare between the ethanol and polydecanol, and we found that the efficacy are the similar. However, the patients with ethanol is complaining of more pain and more discomfortable, and some hoarseness of voice may appear in some patients with ethanol, and it is completely safe among the patients with polydecanol. On the other hand, we noticed in some cases that there is maybe fever if the patient is having a polydecanol injected, which is not seen in the cases much statistically who are using ethanol. So let's go to our topic today, which is the thermal ablation of the thyroid nodules. When you are a medical student, we heard about the thermal ablation for the first time about the hepatocellular carcinoma and the osteocarcinoma, osteosarcoma of the bone. I remember this. What's the difference between the thyroid, especially the benign lesions, for example, hepatocellular carcinoma or the HCC? Number one, in the benign thyroid nodules, we are not aiming to completely ablate the nodule and above it or beyond it. We are aiming to shrink and reduce the size of the majority of the nodule to make the volume reduction ratio more than 70 to 80% and more. Most of the studies and the clinical practice, if the nodule is shrinking more than 50%, the compressive and the cosmetic problem of the patient and complaint is improved. But when you are dealing with the hepatocellular carcinoma, for example, we are aiming to distract all the mass or all the focal lesion and to have a safety margin beyond it to make sure that we are curing the patient, not just shrinking this mass. For example, this is a thyroid nodule, and here is the antenna of the microwave. When you are doing moving shots and ablation, we are aiming to shrink the size to be more VRR, more than 80%. This which is improving the complaint of the patient. But if you are dealing, for example, with the hepatocellular carcinoma, we are aiming to ablate all the lesion and beyond it to make sure that you are curing the patient from the cancer. I'm an endocrinologist, and every time I start to speak about the thermal ablation, how did you enter it? And also, I'd like to polish my youngest students and residents and followers about how to use or how to enter in the career of the thyroid thermal ablation. I usually remember this case. This is a case of single lady, started to having a toxic adenoma and clinical symptoms and signs of hyperthyroidism. By examination, she's having asymmetrical neck swelling. I did for her the thyroid function test, and it showed the suppressed TSH and elevated free T3 and free T4, which is indicating the hyperthyroidism. And when I did ultrasound for her, I found a left solitary thyroid nodule, thyroid 3. According to the guidelines, I did for her the thyroid scan, and it resolved that it is have a hot nodule. So this is and her relative that we have three options at that time. This case, I remember I saw it in 2018. I discussed with her that we have three options at that time. The first option is the surgery to do lipectomy, but the patient will marry after 3 months. So the patient and her mother refuse completely to have a scar in the neck region. Then I told her we have an option, the radioactive iodine, but we should postpone either your wedding or the fertility for 6 months from now. She told me, no, please, I don't want to tell her husband or the relatives, I don't want to delay the wedding. There is no medical treatment. I told her, okay, we can take a medical treatment, which is the carbimazole or propylthyroxine. But after you finish the pregnancy and the lactation, we can find a curative method for the other, either iodine or the surgery. So I prescribed for her the medical treatment and I commenced her on the carbimazole and the propranolol. After a few days, the patient and her mother come to me, which is developing jaundice, nausea, and itching and yellowish discoloration of her eye. And the laboratory investigation after exclusion of the other cause shows the pattern of drug-induced hepatitis. So I think what to do now? The patient is completely refusing the surgery. Radioactive iodine patient is also refusing. I'm afraid to shift here to the propylthyroxine, which is a more hepatotoxic. What to do? So I searched in the literature, and at that time, just the thermal ablation is entering Egypt. And I referred her at that time, I'm not practicing thermal ablation, but I referred her to do thermal ablation, and the patient was cured and everything was okay. So I started to learn, and this the case I remember it, polish my mind and make me interested in the interventions of the thyroid. What is the advantage of the thyroid thermal ablation in a comparison to surgery? Surgery is the gold standard treatment for any thyroid enlargement, but the thyroid thermal ablation have a lot of advantage in comparison to surgery. Number one, that there is no scar. It is not logic that I having a mass causing disfigurement in my neck. To remove this mass, I leave this scar. So this is sometimes making issue for the ladies. Although a lot of my colleagues from the surgery department do perfectly and elegantly transaxillary or transoral thyroidectomy, but it is not suitable for all the cases. To avoid the scar, not suitable for all the cases, and not a lot of surgeons are doing this. Also, as an endocrinologist, I hate to deal with a case of post-thyroidectomy hypoparathyroidism. If you are doing thermal ablation, there is no case in my experience and no case in the literature developed hypoparathyroidism because we are very away from the parathyroid. And even if you injured one parathyroid gland, there is a lot of other parathyroid which is doing its action perfectly. Also, the patient is not needing lifelong replacement therapy. There is no need for regular short-term follow-up. The patient is not needed to take calcium or vitamin D if the parathyroid gland are injured. The quality of life are maintained. All of this are evidenced by studied and local Egyptian and international experience as an advantage of the thermal ablation in comparison to surgery. Also, thyroid ablation could be completely done from A to Z by local anesthesia, which is minimizing the cost of the hospitalization and anesthesia and the contraindication and the hazards of anesthesia. The patient, and it is a short duration, less than an hour, you are finishing the patient, and the patient is just to stay 2 hours under observation and go to his home. If you compare the thyroid thermal ablation, if you are an expert and doing it or doing it under supervision, very, 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 very low major complication in comparison to surgery. So this is all of this are advantage of the thyroid thermal ablation in comparison to the surgery, which is the gold standard treatment for the thyroid nodules causing compressive or cosmetic problems. Apart from treating of benign thyroid nodules causing compressive or cosmetic disfigurement, also if the patient is having a toxic adenoma, especially if the total volume is less than 12 milli, I can do thermal ablation. So I'm avoiding the hazards of radiation from the radioactive iodine could be done even in pregnancy or lactation. There is no problem. The patient is not taking carbimazole, nor is no scar and no problem of the surgery. So all of this are advantage in treating thyroid toxic adenoma by thermal ablation in comparison to the surgery or the medical treatment or the radioactive iodine. Also, a lot of evidence are growing, more than thousands of cases. A lot of papers are coming from Korea, South Korea, and China, and Europe, and Latin America about treating the thyroid microcarcinoma. If there is no lymph node metastasis, if it is safe away from the dangerous triangle, you are confident to do ablation for the nodule and the safety margin above it, you can treat microcarcinoma versus the active surveillance, and a lot of evidence is supporting this. Perhaps you are referring the patient for surgery and the surgeon is doing his job and remove the thyroid and do lymph node block dissection. And with follow-up, there is a metastasis of the lymph nodes, solitary or two lymph nodes lost or did not removed by the surgeon. You can do also thermal ablation for the lymph node metastasis if you are confident and it is away from the dangerous triangle, the dangerous areas. You can do thermal ablation for it. Simply, Professor Bulent will discuss it in details, but simply we are ultrasound guidance with a local anesthesia, entering the needle, and after doing hydrodissection, we're doing the ablation, then we evaluate the patient after that. I just want to highlight on some points that number one, we should explain that the procedure for the patient, that it is nearly similar to the FNA procedure, but it is longer in time, maybe quite painful than it, but it is completely tolerable and very easy. We should also highlight for the patient that the mass will not be removed. Apart from the microcarcinoma, when we are dealing with a when we are dealing with a benign lesion, we are not removing the mass. We are causing shrinking for the mass. So this is help in removing your problem in the compression or the cosmetic problem. On the other hand, we are saving the thyroid tissue to perform its normal function. Also, if the patient is having hyperthyroidism and toxic adenoma, we can make the patient by thermal ablation stop the carbimazole. But if the patient, a lot of patients come to me having already hypothyroidism, and they are thinking that if we are doing ablation, we will stop the levothyroxine. No, the ablation is either to treat a mass and decrease the compression or cosmetic problems, or to make the patient, if it is a toxic adenoma, to stop the carbimazole or the antithyroid drugs, but not to compensate the levothyroxine and make you stopping levothyroxine. We should make sure that it is a benign. We take 2 FNA or 1 true cut biopsy. I'm not a big fan actually of the true cut. I usually take 2 FNA to make sure that it is a Bethesda 2. If you are dealing with a Bethesda 3 or Bethesda 4, if you don't have molecular testing in your country, it's better not to do thermal ablation because you are not making sure, and the percentage of thyroid malignancies is more than 10%. So it is not a good case, especially to start with it. Bethesda 1, if you are doing with a solid nodule, it is non-satisfactory. So you should take again 1 or 2 samples to make sure that it is a colloid materials. The only case that you can deal with a Bethesda 1 and do ablation if you are doing a huge cystic lesion and it is showing no cellular tissue, so you can feel free with the Bethesda 1 and do ablation. You should make sure that the patient is not having a bleeding problems like hemophilia or decompensated cirrhosis or taking anticoagulation or antiplatelet. You should stop and collaborate with your cardiologist, or if you can do it by yourself, you can manage it and stop the antiplatelet and anticoagulation, then return it after the procedure. You should stop it from 3 to 5 days before the procedure. I'm regarding the antiplatelet. And shift the patient for the low molecular heparin. If he is taking oral anticoagulant, shift him to the low molecular heparin and stop it the night of the ablation. There is an exclusion criteria, and especially those who are not expert or who are starting the career. This is one of my mistakes in the beginning. Please don't begin with difficult cases. begin with the easy cases. Because if you are beginning with the difficult cases or suspicious cases, you are increasing your mistakes in beginning of your career, and maybe you are suppressed. So please, if the patient is having a bleeding tendency or severe cardiopulmonary disease, advanced COPD, advanced heart failure, tense ascites, the patient could not lying flat, comfortable for more than 30 minutes, please avoid these cases because it need a person like Professor Pullen who is and within few minutes is doing the case, and he is very confident and he is very rapid and he's very skillful. If you are in the beginning of your case, please avoid this case and refer it to one of the experts near you or even the surgery. If the patient is having, as I said, follicular dysplasia, Bethesda 3, Bethesda 4, you don't have molecular testing in your country, so please don't do ablation for it. If the fine needle is benign, this is one of beginning of my mistake in my career. It is a Thyroid 4P or Thyroid 4C or even Thyroid 5. And even if you take one or two fine needle and it is benign, please don't do it. Because when you are taking FNA, we are not 100% guarantee that this is a benign. It is most of cases. So if it is a Thyroid 1 or Thyroid 3 or Thyroid 2 and it is benign, you can do it. But if the ultrasound is having suspicious criteria, lymph node, microcalcification, severe hypoechoic, ill-defined, so please don't do it, even if the FNA is benign. This is a very simple procedure, and Professor Pullen will highlight it as I say in the schedule. But for me, especially as an endocrinologist or interventional thyroidologist, for me, number one, in dealing with a benign thyroid lesions is the safety. Number one, and even number 10 is the safety, then the efficacy. And from my experience in the last year, to be as much as no complication or near zero complication, you should do three things. Number one, do good hydrodissection, either anterior, lateral, posterior, tracheoesophageal. Do good hydrodissection. The more hydrodissection, the more you are feeling safe, the more comfortable. In the beginning of my career, I'm afraid from injecting a lot of fluids, feeling that the patient is maybe having suffocating or something, or feeling like compression. This is not happening. Professor Peck is reported that he is, in some of his literature, that he is injected up to 300 ml doing hydrodissection. Me, as myself, in some cases, I inject more than 200 ml for hydrodissection. Nothing has happened. The more hydrodissection, the more you are feeling safe and the more isolation of the temperature from the dangerous surrounding areas. Number two, you should be good in ultrasound and good visualizing the tip of the antenna. Please don't burn if you are not seeing the tip of the antenna, because in few seconds you are may burning important structure. Number three, using the moving shots technique, and Professor Point will talk about it. Also, if you are dealing with a big nodule, more than 4 centimeters, having a retrosternal extension, our colleagues from Latin America and Italy reported the iceberg technique, which is burning the cervical part, and after 6 to 12 months, do a stage ablation or a second session of ablation. Here is one example of my patients. It have a goiter. I could not even measure that by ultrasound, clinically even more than 15 centimeters in the length with a retrosternal extension. She's completely refusing the surgery. Her sister is having surgery and developed a tracheostomy. Then she's died, so she's had bad memories with the surgery. She told me, I will never do surgery again. I told her we have a possibility that we are having a malignancy, regrowth, injury, we need a staged ablation. She told me, okay, I can do everything apart from the surgery. I ablated her, and here is, as you see in the video, before the ablation, before microwave ablation. Then after 6 months, all the cervical part, most of it disappeared, and the mediastinal part started to appear in the neck. I offered her the second session of ablation. Even she told me, no, I'm comfortable with this. I don't need any other thing for ablation. After it, for my personal experience, I keep ice pack for 1 hour and observe the patient even in the outpatient clinic. Then I give him prophylactic antibiotics if he's a high risk to be having infection, for example, advanced age or taking steroid or diabetic. Non-steroidal and anti-inflammatory for 3 days, and everything will be okay. Usually, I follow the patient after 1 month, after 3 months, 6 months, 12, then annually. If the patient is already euthyroid, I do not repeat the TSH except after 1 year. If the patient is hyperthyroid or toxic, I asked him to stop the carbimazole, then follow up with him with TSH and free T4. And as an endocrinologist, I would like to highlight that if you are doing ablation or radioactive iodine or surgery or medical treatment, do not rely in the first few weeks after procedure about the TSH. The TSH level may be suppressed up to 9 months. You are relying on the free T4. If the free T4 is normal, so your procedure is successful and everything is okay. Here is my card. I give it for the patient. It is in Arabic. I give this card for you because at the end of the card, I usually ask the patient, because some of patients coming to me from different countries, from away town, they are difficult to come to me again after 1 month or 3 months. So I told them, go to do ultrasound and send me the report to do follow-up. And please, before you are doing ultrasound, please give the radiologist this report. As you see here, I write this in every case that, dear radiologist, your patient is having a history of thermal ablation for benign thyroid nodule. The ablated nodule may look to you very suspicious. If you look for this, all of this are ablated nodules from my patients. If you are not familiar with the thyroid thermal ablation, the thyroid nodule will look for you solid, irregular margin, hypo or severe hypoechoic, maybe microcalcification. You will shout for the patient, this is a cancer. And it is a simply burned tissue. So please, if you are following up or seeing a patient with a chemical or thermal ablation, please be familiar with this picture. Also, if the patient is having a problem, psychiatric issue or disease-related anxiety, when I follow up, and we studied this in a lot of research, when I follow up with the Hamilton Anxiety Score, everything is great for him. The complications of the surgery, the complication of the procedure is either to doing a nerve injury, and you can avoid this by good visualization and doing hydrosection. The pain, and you can avoid it by reassurance of the patient or giving him a non-steroidal 1 hour before the procedure and good local anesthesia. Maybe hematoma, maybe some fever, some infection, but all of this, if you are comparing it with the surgery, is much lower than the surgery. Regarding the evidence, a lot of thousands of papers are there. And I summarize for you this table showing the guidelines from 2012 till 2025. And still the guidelines are coming. Started from South Korea, China, Italy, Europe, Latin America, Taiwan, USA, European Society, UK itself. A lot of guidelines are coming, and a lot of guidelines are there to support the evidence and put the positioning of the thyroid thermal ablation. In Egypt here, we like the European and American guidelines. In Egypt here, we love the European Thyroid Association guidelines, and it's stated in a consensus about the practice guidelines for the use of image-guided ablation for benign thyroid nodules. And even in 2021, after thousands of papers coming from China and South Korea about the ablation of the microcarcinoma, and it is stated that it is having a superior evidence in comparison to active surveillance, but needed to be tailored in such cases, not all cases of thyroid malignancies. The British people are always resisting putting new thing. Finally, they are putting it in textbook, the British people, that putting the radio frequency and the microwave and thermal ablation is there and could be done for the patients. Finally, I finished, but I just want to share with you some of my cases. I like it, and even I show it in my conferences. And even those patients, if you are not seeing the thyroid by itself, they are feeling that it was a dream. If they are not seeing the old photos, they don't remember how the catastrophe is. Here is one of patients who have a right thyroid nodule. As you see it, it is causing cosmetic problem. Just after few weeks, complete improvement of the case. There's another case. before ablation, right nodule. Just after few weeks, improvement just under local anesthesia without any scar. The more solid, as I will see now, the more solid, the less volume reduction ratio. As you see here, this is a solid case, so the VRR is less than the cystic or mixed or spongiform cases, the first two cases. I love this patient actually. This patient is I think, 19 or 20 years old lady. She's refusing to meet any males to be engaged and to be married because she's having this problem in her neck and she's refusing the surgery. She's having a huge ethmic and left-sided mixed solid and cystic, mainly cystic. I love these nodules. It gives a marvelous result. Look for the results for such case. This is before ablation. Just after a few weeks, complete normalization of the compressive and cosmetic problems. It's a great, it's a magic actually if you are choosing the cases, and this is the final case. So, dear colleagues, let me end my presentation by take-home message. I usually say this, I usually remember the Indian guy, which is Mahatma Gandhi. First, they are ignoring you. Then they laugh from you. Then they fight you. Then you win. All this stage, I passed in it in Egypt. In the beginning, I started to talk and to practice thermal ablation in 2019. No one is talking with me. Then they laugh from me. Then they are fighting me. Then I consider myself win on them. Those who are young colleague, who you are endocrinologist, radiologist, nuclear medicine physician, oncologist, surgeon, whatever you are, for me, if you want an advice, number one, be professional at the ultrasound. The most difficult part is the ultrasound. Be professional in the ultrasound, everything will be okay. Because the simple ultrasound you see in the textbook or in your clinic is completely different for the ultrasound with ablation and gases and hydrodissection and. So if you are not good in the ultrasound, you will be lost and burn another problem. At least start to do 50 FNA successfully, then start with the chemical ablation, then start thermal ablation under supervision of expert, then go by select the easy case. For my opinion, this is my advice for those who are beginning in the career of thermal ablation. Start with a purely cystic lesion, which is resisting to the chemical ablation, or the mixed or the spongiform nodules. As you see here, I found in the studies and in the literature and the experience that you are having or achieving within few weeks VRR more than 80 to 90%. Some of the cystic nodules, it is disappearing. Even I stay sometimes to try to find the scar even of the cyst after 1 year. If I'm not make sure that this is my patient and this is my ID on my medical record, I will think that he is having a completely normal ultrasound. Please, in the beginning, avoid those solid nodules with a high vascularity or with a calcification, because there is still a risk of malignancies. The risk of recurrence and regrowth is high. The VRR is low, and even the procedure itself will be difficult for you and take a lot of time and will be more painful for the patient. My conclusion, that you should have a team. If you have a team, it will be very easy for you. Educate them and learn them. You should stay comfortable. Your chair, your patient is comfortable. The ultrasound, the machine, the screen, everything should be comfortable for you. The more anesthesia you are doing for the patient, the more relaxation for the patient, the more reassurance of the patient will make your procedures easy. Always, for me, I advise you, especially when you are doing ablation for the posteromedial part or near the dangerous triangle, always talk with the patient about anything to make sure that the vocal cord is freely mobile and nothing is happening. And even if some hoarseness is happening, just if you are stopping ablation and even injecting cold saline, everything will be okay. And if you are not seeing the tip of the antenna, stop just a few seconds, 1 or 2 minutes, everything will be clear. The gases will be removed from your vision and your scene, so you can continue again. Moving shots is very important, the most important part, and always remember to burn when you are seeing the antenna. is this message or my lecture that you are saying bye-bye to surgery and there is no rule for surgery? The answer is no. Surgery is still having a rule. Surgery is having a rule in a grave disease, in a toxic multinodular goiter, in a huge retrostenic extension, in a patient with a malignancies with a distant lymph node metastasis, in a patient who are not covered or not insured by their countries for thermal ablation. Surgeries still have a rule. But as I said, if you are dealing with a cystic lesion or a spongiform lesion or solid with a low vascularity without calcification, why to do a surgery while you are having something to solve his problem, which is a novel, which is FDA approved, which is having a lot of guidelines, and which is life treating and making the patient is not needing a lifelong treatment. The main issue for me in my country is the cost. Even in some areas in my country, the thermal ablation itself is more costly than the surgery. But in Europe and in USA, and even some countries, the surgery of the cost is double or triple the surgery of the thermal ablation. But this is my main problem in my country, which is the cost is the main issue. Thank you again. Here is my contact and happy to be with you. Happy to have a question. Either, I don't know, Dong, if it is in the end of my lecture or end of the session. Happy to hear any question for you. And happy to hear from my big brother and my mentor and my teacher, Professor Pulent, about his lecture. And I'm sure that we are enjoying it.
Thank you.
Thank you, Professor Hossein. And now I think we're going to handle the chair to Professor Bulent. Yep.
Okay.
Can you see it?
It's opening, Professor Pulent. Still till now not opened.
It's open, yeah?
Not yet. For me, not yet.
1 minute.
Still in the folder.
Can
the
you
PDF.
now?
No, for me, no.
No.
1 minute.
So when you click the share, maybe can you share the whole window, like whole screen?
One minute. Okay. This is my 1 minute. Okay. Now I change again. Sorry. No, not here.
Can we have some questions answer? Don't tell Professor Polent, you can read the question and I can answer it. If there is any question, I'll see in the comment till he finished his issue. Is it okay, Dr. Polent, for you?
Yeah, of course.
Okay. If you have, you can read the question. I think there is some questions. Dong, you can read it.
Yes. So first one, I think from which anesthetic do you use for thermal ablation?
Which what?
Which anesthetic?
Yes, most of guidelines is recommend to use the lignocaine, 2%. For me, I learned this from my colleagues in the anesthesia that I usually give the patient 1 to 2 hours before the thyroid ablation. I give him 2 grams of paracetamol and 400 milligram of ibuprofen, if it is not contraindicated, of course. Then I put for him local lignocaine cream on his neck. Then I use a mixture between lignocaine and bupivacaine and dexamethasone. I learned this from my colleagues in the anesthesia, that it is a prolonged effect and even decrease the anti-inflammatory or the edema after the ablation. So I use this protocol in my in my procedure. So the floor now for Professor Poland, and after that we can continue.
Is it
Yes,
open now?
Yeah, yes, sir.
yes,
It is
it's
open.
perfect.
Okay. Okay. Thank you.
Thank you, thank you.
Now, today, thank you for me invite. My English is not so good, but I try to my friends. Firstly, irreversible cellular damage is very important damage. Therefore, sorry, we look at my optimum coagulation for tissue is between 60 and 100. More than 100 Celsius is not good. Why? Because the best thyroid thermal ablation is between 6 and 80 Celsius. When we do it, then we see it cytotoxic effect, cell death, coagulative necrosis, and destroyed and phagocytate immune system. But when we more than 80 Celsius see this, the problem is macrophage. This is not good. Therefore, it is very important. The optimum thermal ablation is between 60 and 80. In which ablation we do indication? Firstly, between cystic nodules contains between 70 more solid component. Solid and mixed tip nodules under 30 Celsius, autonomic toxic nodules, growing nodules. Why? Because there was some in detection of more than 15 growth per year in the tear needle. Thyroid nodule, previous thyroid surgeon, parathyroid adenomas, papillary microadenomas, and general anesthesia. I use normally these diseases, and the optimum is between 20 and 30. The advantage is because the active is 3.5 millimeters, it is very small and more safe. Sometimes I use RFA. What are the RFA compared to firstly, the antennas used for RFA is more than thinner. Secondly, most of them are works according to the tissue impedance, and it goes up to maximum of 800 ohm. And therefore, the protective negative effect on carbonization, and it is very old. When we're using microwave ablation, we use it large ablated tissue volumes, optimal heating in cystic nodules, hypervascular nodules, toxic adenomas, less pain during the procedure. There is no ionic current passing through the body implant, and tissue impedance doesn't matter. And if the patient have some grounding pads, pregnancy, basic, in these cases we can use MBA but not RFA. And in some patients, patients that increase volume reduction rates, best candidates for thyroid ablation are spongiform echostructures, nodules with liquid component, intense peripheral and intranodal tonsil vasculature, and soft nodule shear wave elastography, less than 30 kilopascal. This is very important because one of my this is my I make sometimes nodules with the shear wave elastography volume above 60 kilopascal with micro have a value between 50. This means if the more than 60, it's not good. Therefore, it is more less than 60. Otherwise is technical factors that affect the volume, operator skills and experience, ablation of peripheral merging of thyroid, and hydrodissection. We have now another özellik. This is toxic adenoma or nodule functions. This means this, if the patients less than toxic adenoma, less than is only 10, then we beginning with F or with microwave with thermoablation plus 90 ethanol injection. In these cases, we have in 1 month 95 normalization. This is very good. And we did to this thermoablation plus ongoing chemical operation. When the procedure has patient's story, growing nodules, this means some patients have more than 20 in 1 year. In this we do it ablation, or if the patient have from a surgery thyroid nodule and private thyroid surgery, in these patients in recurrent thyroid nodules after thyroid thyroidectomy, and surgeons refer to ablation rather than and secondary, and therefore in this have a very big for recurrent laryngeal nerve. Another new is fine needle biopsy result. Firstly, benign, okay, no problem, but sometimes Bethesda 3 in these tips have ITP and unsurgical sensitive aus. In this case, if the patients have only structure and ongoing, we can do it. But if the only nuclear ATP, we don't do it. Therefore, most of from especially from China, they will make the 9 tanks and they say to us only we make the big but the small not do. And neither is fine needle biopsy result follicular neoplasm. And in this graph, 80 follicular Adam and 20 is follicular carcinoma. In this, we speak with the doctors and they say when the Bethesda 4 nodule are smaller than 2 centimeters, you can do ablation. But if it's bigger than 2 centimeters, and there's in many one of my if it's only ethanol ablation, we only mostly cystic. But if the patient have only combination therapy, we do it with ethanol ablation and RFA, and with thermal ablation only ablation. Risk assessment and thyroid ablation. And if a patient come to me and 5% have toxic adenomas, in these patients we look with toxic adenomas and contralateral thyroid lobes atrophic, and we look at to Racus thyroid scintigraphy. But in some patients, if they have high thyroid autoantibodies, in these cases have a high risk for autoimmune hyperthyroidism or Graves' disease. Therefore, in these cases, we are importance. This is very nice. Normally, we know that we using danger triangle. What mean this? Normally, we only using here. What mean this? That we normally tracheoesophageal growth. But now, the anatomy is different. Therefore, we have a new name. This is danger zone. What is this? Here. This is from Professor Bay. We look to the chain, cook to the nerves vagus. Here says the standard at the number 1, 12, or here or here. But this is very dangerous for nervus vagus. What I do, this is my pictures. When you see the nervus vagus as changing from superior to inferior, it is very important. What mean this? This mean it's changed the position. Therefore, in every patient, we must that controlling. Other, this is another people. We see here anatomical from the patients, and we see Horner syndrome before we see it, and after it's changed here. Before patient have I give a combination, but then we give to the patients cold and 40 millimeters, and everything is normal. And this is very important. Right vocal cord paralysis. When we look at, we see here is nothing. Then we give some things, and it's normal. In some cases, voice change during the procedure immediately after ablation, mostly lidocaine effect or stretching the nerve over hematoma or hydrodissection, or thermal injury. Sometimes when we have an emergency kit for thermal nerve injury, first we give recurrent laryngeal nerve, or we give between thyroid and carotid artery, nerves vagus and middle cervical ganglion. When we beginning 20 cc cold dextrose plus 20 milligram methylprednisolone mixture, super result, and in 5 or 10 minutes it's totally normal. In the beginning, sorry, in the beginning we give 10 cc to lidocaine here, and we give it to between this to this, and sorry, first with this is hiding. This is before ablation. We go to inside microwave and beginning slowly. But when we look at with radio frequency, we go. The difference is it's 7 centimeters. It's bigger. Sometimes we difference. When you look, ablation is little more bigger. This is the same thing we have here for my patients. And this is toxic adenoma ablation. Before it was very small, but after ablation we see nothing. It's totally, after 3 weeks, everything was good. Uh, we speak about this, and when the approach to the toxic adenomas above than 100 cc, then we must using 20 or 40 for the patients, but this is very problematic, because if we use it, we have hypothyroidism developed in the 55 in individuals. Therefore, in your approach to such nodules beyond plate thermal ablation techniques in low doses, the approaches reduce the risk, hypothyroidism, and recurrence in toxic. Sorry. And therefore, before ablation, we give the patients propranolol and methylprednisolone, and everything is very good. And now we begin to do papillary thyroid microcarcinomas. And there are two. One is from China and one is from Italy. But for me, is China is better, more intensive. I think they are better here. And in this, the carbon the doctor surgery and ablation. When we looking the difference, the doctors are totally normal. And here is from China. We see here the papillacea. We do ablation after 1 month, not so but after 3 months it's changed. After 6 months, totally normal, 12 normal. Here is another operation. There is a, I give here little water, and here, and then we do ablation. It's going. Here is for my and shouldering, and this is my patients. Before it was very big. I ablated it very big. After 3 months, after 6, nothing. Now we change the normal parathyroid glands. Is very different. Normally we don't see maces, but this is normal parathyroid. And normally, when we looking to parathyroid lipoadenomas, there are more white. This is white. This is white. Now it's very different. And therefore, there are difference. Normal, it is white like this, but normal parathyroid is uh, in this. Why? Because if the patient have only parathyroid gland, you have only fat tissue. But if it's normal, only different. Here is different parathyroid lipoadenoma and parathyroid adenoma. If this parathyroid linostromal fan is dominant, but if it's parathyroid adenoma, it is chief cells are dominant. Ultrasound more ultrasound more hypoechoic. Sphere is more softer. Normally is more big, and PTH is one between 30, but in big, very big. Here is a firstly we go with we give him waters, and this is a pathology. Firstly, I give, and second, I go with the needles inside. Then we give it only totally 1 minute. When we give it, when it's totally go finish. Case 2, it is 20 years old woman, big. When I look at it was very big. It was 40, 28, and 20. That's very big. Before we give little some ticks here, it's because it's too big. Therefore, I give too much. And then we beginning to ablation very fast. And before it was so, but after it was so, you see the difference. But the problem is in these tips directly we see hungry bowel syndrome, and I learned math from things from the doctors, hungry for syndrome and hungry for syndrome. In these cases we see PTH and hyxia, and sometimes pre-operative optimized vitamin D. Most of this I do it with my friends. They do better than us. And this we begin new. This is microvascular imaging. In some CDs, Philips, Samsung, General, them have different. What is this? This is one of my. This is a PTH, but we give before later. After we see it's good, but when I'm using micro flow imaging, we see it is totally good. Another before, after, very, very good that I now understand it's here is very small, but the problem is it is very too after ablation we see nothing, but after ablation we see with microfreezing it is finished. It's very important. And this is a patient's doxan 90 cc, but after 3 months it is 3.5 cc. And the take from patients is patient selection is very important. Use always shear wave elastography, softer nodule, more significant nodule reduction. Performing ablation with the lowest possible watt is important. Lower watt, better watt volume, rather. And careful anatomical assessment before the procedure to be knowledge about management potential after the procedure. Thank you very much.
Okay, thank you, Professor Bulent. And I think we still have around 20 minutes for our Q&A sessions, and I see a lot of questions in our chat box. I'm gonna ask from the orders. So after the anesthetic question, there is one question about how many watts should be used for ablation. Maybe for Dr. Bulent, how do you set up the watts when you do microwave ablation?
Between 20 and 40.
Between
It's
20 and
dependent.
40?
Yeah, it's dependent on the tires. Is it small? Is it big? Small? It's dependent. Therefore, it can be changed.
All right, noted. And another one from Dr. Stepan for Dr. Hosam. Why you are not a big fan for true cut biopsy?
Uh, actually, there is a lot of data suggesting that the 2FNA may have near similar sensitivity and specificity than the TrueCut. The complications of the TrueCut biopsy, like hematoma and pain, and even the cost, is more than the FNA. But the most important thing for me is the standardization because we don't have, even this is from the word of the pathologist, that there is no standardization or Bethesda classification like for the TrueCut. Because if you are dealing with the smears FNA, you send it to any pathologist in the world, he will report it as a Bethesda 1, 2, 3, 4, 5. But if you are doing a TrueCut biopsy, you are dealing with a paragraph. There is sometimes, however, cells, atibia, and you are not sure, make sure. So, and even Professor Peck is mentioned, I think the last year in a meta-analysis comparing the FNA with the TrueCut, does not found any bigger difference in the sensitivity and specificity. So for me, when I do TrueCut biopsy, if I did 2FNA and it is non-satisfactory results, I do TrueCut biopsy. Or even if the nodule is very large, for example, 5 or 4 centimeter or 6 centimeter, I can do TrueCut biopsy. Otherwise, I usually prefer to do FNA from every 2 centimeter of the nodule before I do ablation.
Okay, thank you. And I move to the next question. Is microwave ablation an option for a female patient with a thyroid nodule around 5 centimeter with a history of breast cancer who refused to do surgical treatment due to that diagnosis? And the FNA is Bethesda category 2. So maybe Professor Bullet?
No, no, my friends speakers is better because I'm little not good, therefore. My
Okay,
friend take.
so there is a female patient with
Okay, I can speak.
yeah, yeah, please.
I hear the question. Okay,
Sure.
if you are here, there is some issues you should know about it, and your patient should know about it. To my knowledge, there is no direct relationship between the cancer breast and the cancer thyroid, so there is not issue. It is not a big issue if you are dealing with a such case. If you are doing a nodule more than 4 centimeter, the patient should know some points. Number one, that it's better from my experience and even from the literature to do it a staged ablation because it's very, very difficult to ablate a nodule 5 centimeter completely. Number two, even if we are taking FNA, we are not 100% guarantee that this is a benign. So the patient is needing a lifelong follow-up, and there is a possibility in the future that there is undetected malignancies are in the nodule, so that the patient should know this. Number three, that the possibility of regrowth will be high. If you did it especially in one session, so the possibility of regrowth in the next few years will be high. So if the patient is accepting to have a staged ablation on 2 sessions and she's accepting to do a lifelong follow-up, so there is no problem. You can do ablation. As I said, you start with the cervical part. Then after 6 to 12 months, you can start to ablate the remaining part in the upper part, and then the lower part will be easy to see it. And even I advise also to start by the technique which is reported in the literature by artery ablation first. Usually, if you are moving the probe slowly and near the superior thyroid artery, usually by the Bauer Doppler or the color Doppler, you will notice the feeding artery. You can even enter by the antenna and ablate it first. This will be more helpful to prevent the regrowth in the future and even will make it more reduced in the volume in the next few months.
All right, thank you. I think we have a lot of questions coming up. Okay, so the next question is, what is your approach for bilateral nodules for Dr. Bulent, maybe?
Can you say it again? I don't understand.
So what is your approach for bilateral nodules? So the nodules from two sides, from both sides.
I cannot understand. Can doctor speaking, my
Hosam?
friend?
Yes, Dr. Borant, the doctor is asking what if the patient is having nodule on the right side and nodule on the left side? Do you
Uh,
ablate it in the same time or two different times?
Yeah, it's not important that it's in the slide or it's dependent on your hands. If you have a good hands, you can do it in the boy in right and it's not important. You can do it, no problem.
All right. So the next one is a pretty long one. So there is growing data in ablation of microcarcinoma. The molecular testing, especially with the thyroid, is very expensive. And what are your consideration about ablation of thyroid nodules, Bethesda category 3 to 4, and the BRAF negative could be a good option for this patient for microwave ablation.
Okay, I will start for me and leave the floor for Dr. Bolin to answer if you would
Yes,
like to add
yes,
something. Okay.
you do
Uh,
it better. Yes.
Yes, if the patient is having Bethesda 3 or Bethesda 4, I usually deal with it as a micro. If the patient is having cancer, I will make the worst scenario that the patient is having cancer. So if the nodule is less than 1.5 to 2 centimeter and away from the isthmus, trachea, and from the posterior medial part, the dangerous zone, Dulce's triangle, I'm feeling comfortable that I can do a good hydrodissection. There is no suspicious lymph nodes. The patient is willing to do a lifelong follow-up and he is slightly older in age, I usually do ablation, making it the worst scenario that it is a carcinoma. But before this, I usually do calcitonin washout from this nodule and the serum calcitonin to make sure that it is not a medullary thyroid carcinoma. Because the worst case, even in my cases, more than thousand, ten of thousands of cases, I even 3 or 5 cases in my life, I did see medullary thyroid carcinoma. It is not quite common in my country, but I do calcitonin and the calcitonin washout from the nodule to make sure that it is not medullary thyroid carcinoma because I'm taking the worst scenario that it is a cancer. But if the nodule is more than 2 centimeter or more than 1.5 and it is sticky to the capsule or the posteromedial part or the recurrent Asian nerve or it is deeply seated, I cannot visualize the nodule very well. I'm not confident that I can do a great hydrosection and visualizing the shaft of the needle. So I usually either, if the patient is not doing molecular testing, either to make follow-up every 2 months, sorry, 6 months, or to do molecular testing or the surgery.
Okay, thank you, Professor Hossein. And I think the next question is also for Dr. Buland. Which solution is best for hydrodissection and the long lasting?
Okay, minimum. If I use not only for minimum 15 minutes I give glass because when I give so much, then we have no problem with the water because the water go in 15 dakika. Therefore, I give it in 15 minutes, waiting. If is everything, then we stop it and finish it. This is the I mean. Or my friend
Okay.
can I have some problem with my salt, therefore I cannot so good speaking. My friend speak today.
Okay, Dr. Bolland. Okay, when I went also to Dr. Bolland Center, I learned from her also that he may use Volvin because the patient with normal saline or dextrose 5%, it is within 2 to 5 minutes it usually disappear. But also I saw Professor Bolland in his center is doing
Tamam.
hydrosection with Volvin.
Tamam.
It is may stay 15 to 20 minutes, which is the high colloid solution. For me, actually nowadays, I learned it from Professor Meng from China to do continuous hydrodissection. Usually, if I'm afraid from dangerous triangle, I usually put the needle and make my assistant continuously making hydrodissection. I learned this 2 years ago from Professor, or 3 years ago from Professor Ming, and it worked very good for me. I usually do continuous hydrodissection, not intermittent, except if the nodule is small and I will not take a lot of time.
Okay, thank you. And also from Dr. Manish, he want to know about how do you do the post-procedure management, like the medicine you prefer to give to patient after the ablation. Can
Yes, for
you?
me, if the patient is already euthyroid or if he's euthyroid, I do not give him any replacement therapy or nothing regarding thyroid, and even not doing follow-up except after a few months if or any other new symptoms. If the patient is hyperthyroid, I usually do ablation and enter the patient the procedure while he is euthyroid. Then after the procedure, I ask him to stop the carbimazole, and with the next follow-up after 4 to 6 weeks, I ask him to do thyroid function test. After regarding if you're asking the medication, I usually do not give the patient antibiotics, except if the patient is having possibility for infection. As I said, if he's taking steroid for any other things, if he's immune compromised, like cases of lupus or rheumatoid, or taking immunosuppressant, if he's elderly, if he's diabetic, I usually give 3 days just amoxicillin clavulanic acid as a prophylactic antibiotics. I usually now used, even if this is I learned it from my practice, I give a steroid for all the patient. It's give a marvelous response. Thanks to Allah that I never developed any case of nodule rupture. But I think one of these rules that I'm giving the patient short-term steroid, 5 days, prednisone 20 milligram twice daily for 5 days, unless if the patient is having contraindicated like uncontrolled diabetes or something else. But usually I give a steroid for all my patients, and I ask the patient to drink cold fluids and eating for the first 12 hours. Then after that, he can drink and eat everything. And in the first month, it is usually not advised to lifting heavy objects or doing a heavy exercise, because especially if the nodule is large and near the subcutaneous tissue, to avoid the rupture of the nodule. So this is the instruction for my patient, and the medication I give. This is my protocol. If Professor Poland would like to add something.
Yes, yes. Thank you.
Okay.
Okay, I think we still have more questions. The next one is, what was the emergency regime? Re, what is that?
Emergency kit, you mean?
The question is, what can you describe the emergency regime you described? Yeah, I'm really, yeah.
I think he's asking about Professor Poland. He described
Yes.
that cold dextrose with 40 milligram of methylprednisolone. This is an emergency kit.
Yeah.
And also, I'd like to add for it also in my clinic, I usually do this atropine also. I make in my clinic atropine because sometimes in the beginning, before I did hydrosection, some cases may have the first sign to make you sure that, or not make you sure, to alarm you that there is a vagal injury, that the patient will develop bradycardia and nausea and vomiting. This is a vasovagal syncope. If you just give him atropine IV, within less than 2 minutes, everything will be solved. So usually I add to what Professor Poland is doing, I add usually atropine. After I'm doing a continuous hydrosection, I never face the case of vasovagal syncope, but I advise you also to add it in your clinic.
Professor Woolen, do you have something else to share about this?
No, no. Thank you.
No, okay. Okay, next one is also from Professor Bullen's share about PTMC ablation of isthmus location. Can we do it, or every isthmus lesion is very high risk
Yes,
about the
yes.
PTMC? Yeah.
Because it's close to the bone, therefore we must go before ablation good with the water, some interesting. When we give around 30 or 40 cc, and then it is close and we can do it. It's very easy. Important is that we can separate it with the, if we can separation, we can do this. But in some cases I cannot separation, then I don't do it. When I cannot do, then I can do it. My friend can
All right.
speak. What is my
Yes,
friend?
it's true. It's true, sir. I agree with you. But for me, actually, I never see a case like this. But the surgeon is always say that those nodule with the isthmus is high risk to make a distant thoracic or chest metastasis. I never see a case like this. I asked even my colleagues in the surgery, they have never seen a case like this. But it is written in the textbook that the ethnic thyroid cancer may have a distant metastasis without cervical lymph node. So for me in Egypt, I do not usually prefer to do cancers in the isthmus unless patient is absolute contraindication or very high risk for the surgery. Otherwise, theoretically, it may carry the risk to distant metastasis without lymph nodes in the neck. And as Professor Pullen said, that you should 100%, it's must to do hydrosection, and you should separate the thyroid tissue from the skin and from the trachea, because you are just touching the trachea. If you are doing ablation without complete careful hydrodissection from above and down, 100% the patient will cough, and he will remove the needle, and it will be a catastrophe, and there will be injury to the trachea.
All right, thank you, Professor Hossein and Professor Bulent. And the time is clicking. I think we still have another 3 questions. The next one is, what is the right technique for hydrodissection of the recurrent lanyard nerve site?
I think it depends upon how you feel comfortable. For me, I can only work by my right hand. I cannot work properly by my left hand. Professor Polent, mashallah, he can work by his right hand, his left hand, and a lot of my friends also can work with both. But for me, I can't work except by my right hand. So it depends. As I told you now, I'm doing a continuous hydrodissection. So my protocol now is usually to insert a needle just paramedian to the paratracheal and enter from the isthmus and put it in the tracheoesophageal groove and do a careful hydrosection and then fix the needle. And always I'm asking my patient, my assistant, to continuous hydrosection, especially if I'm doing ablation near the tracheoesophageal groove. If I'm dealing with a parathyroid, especially the inferior parathyroid adenomas, or if I'm dealing with a posterior nodule, usually sometimes I come with another needle from the lateral to make the hydrodissection is completely isolating the dangerous, not triangle, the dangerous zone that Professor Pullen mentioned. The dangerous zone is completely isolated and making the thyroid like an island in the sea. So to make free and feeling free that when you are doing ablation, the temperature is not reaching either the carotid sheath, either the posterior part of the recurrent laryngeal nerve, or it is variation. Even I learned this from my colleagues from my surgery, because in the beginning of my practice, all the recurrent laryngeal nerve cases, injury on the right side. Till now, I have, so like some conditioned reflex that if I usually prefer the left nodule over the right till now. And I learned it from my colleagues from the surgery that sometimes in a lot of patients, the right recurrent laryngeal nerve is coming with a transverse course, not like the left. So it may be sticking to all the right sides, coming all in the dangerous zone. So it is not just isolating the tracheoesophageal groove, also the posterior part. And especially, I'm very cautious and doing a good hydrodissection, especially with those after surgery. Because with fibrosis and with recurrent surgery, usually the anatomy of the recurrent laryngeal nerve is changing. So you should make sure that doing hydrodissection.
All right, thank you, Professor Hossein. The next one is also to Dr. Bulent. What about multifocal papillary microcarcinoma? It is suitable for ablation.
Yes, yes, it is maximum 1.5 centimeters, and if it's in the good population in the middle of the thyroid nodule, and if we do minimum extra when it's 1 centimeters, but I mostly 2 centimeters ablation, and in 3 and in 6 out. Most of them are very good. But I say you, not in every patients. Firstly, we must see is it good for ablation. What say my friend? Husam. What you say, my friend?
Yes, sir, like you, but actually for me, I'm afraid to do ablation for a case of multifocal, especially in the young age. But if the patient is also elderly and is just for a palliative treatment, we may do it. But for me, I have no experience with it. I haven't did a case with a multifocal papillary thyroid.
All right. I think we have another last one question is how do you do a stage ablation? Do you approach the thyroid mass if you plan to do ablation in stages?
Yes, the first thing is to search for the feeding artery and do ablation near its entry to the thyroid nodule. This is very helpful to help you in the future to make more reducing in the site. Number one, I ablate as much as I can in the cervical part. But usually, I learned this from my Indian colleagues that the ablation time should not exceed 20 minutes because a lot of thyroglobulin will be released in the blood, like the crash syndrome. If you remember it in the medical school, if you are doing a crash syndrome, a lot of myoglobin will be released of the blood. So a lot of thyroglobulin will be released of the blood, and the patient is usually complaining in the next week for severe myalgia and sometimes fever and evidence of thyroiditis, and the risk of nodular degeneration is high. I learned this from my colleagues in India. They call it post-ablation syndrome. So for me, I do not exceed 20-minute ablation time. I'm not talking about the procedure. I'm talking about the timer on the machine itself. I usually don't exceed 20 minutes. I usually postpone it to the other side. Ablate as much as you can in the cervical part, but please don't forget to ablate the artery or the feeding artery first. Then after 6 to 12 months, the lower part will be appearing in the neck as I showed in the video, so we can do ablation to the remaining part safely.
Okay, the very last one question for Dr. Hossein. Do you do bilateral nodules in one session?
If they are small and both of them are away from the recurrent laryngeal nerve or the dangerous area, yes, I do it. If the maximum diameter for each one, for example, 2.5 or 3 centimeter, I do it. But if I'm doing, if they are both of them are close to the dangerous area, both of them are posteromedial, both of them are big. No, usually I do one side, the bigger first, or the most superficial or the most symptomatic for the patients first. Then even after 1 month, I do the second one.
All right, I think we basically come to the end of today's webinar. I'd like to extend our heartfelt thank you to our speaker, Professor Hossein and Professor Bulent, for sharing their invaluable insight and expertise. And we hope you find today's discussion very informative and inspiring, and stay tuned with us for future events. And thank you all for coming. Until next time, good morning, good afternoon, and good evening to everybody come to our webinar today. I hope to see you guys next time. Thank you.
Bye-bye.
Bye.
Thank you,
Bye-bye.
Professor Bolin.
Bye.
Thank
Thank
you,
you.
Don. Bye-bye. Bye-bye.
Bye-bye.
Have a nice
Bye-bye.
Bye.
day.
Have a good day.
Bye bye.
Bye.